All right, calling to order the meeting of the Health Insurance Reform Commission for Tuesday, November 15th, 2022. We have introduction of members. Maybe what we should do is before we have the roll call, just go down the list since we have a number of new House members. So, in fact, I think all except for Lee Weir. So, go ahead.
My delegate Joe McNamara, representing Roanoke County, City of Salem, Craig County, part of Montgomery County. I'm glad to be here.
Kathy Byron, part of the Campbell, Bedford, Lynchburg, and Franklin County, 22nd District, a former member of HERC.
Yes. And I'm George Barker. I'm chair and State Senate, representing parts of Alexandria, Fairfax, and Prince William.
Good morning. I'm Rip Sullivan. I represent the 48th District in the House of Delegates. Glad to be on board, Mr. Chairman.
Certainly.
Scott Surville, 36th Senate District, which is Fairfax, Prince William, Stafford counties, more hot lanes and VRE rail than anybody.
Lee Ware, I represent the 65th House District, Powhatan, and parts of Chesterfield, Goochland, and Fluvanna.
All right, and Mr. Secretary.
Good morning, John Littell, Secretary of Health and Human Resources. Glad to be here today.
All right.
Hi, Scott White, Commissioner of Insurance for the State Corporation Commission, Bureau of Insurance.
All right, and can we have a formal calling of the roll here to make sure we have a quorum? So.
Senator Sasslaw, Senator Surville, here. Senator Spruill, Delegate Ware, here. Delegate Byron, here. Delegate McNamara,
Here.
Delegate Sullivan, here. Commissioner White, here. The Honorable John Littell, here. Senator Barker,
Here.
You have a quorum, Mr. Chairman.
All right, thank you. We're going to tackle a few things today. This is our first meeting of the year. I'm quite pleased that the four people who have been appointed to represent the House of Delegates just recently got their calendars in shape to be able to be here today. So we will now move along to the second item on the agenda, which is the overview of legislation referred to the Commission during the 2022 regular session. Mr. Stevens, you want to present us with information on basic information on that? So.
Thank you, Mr. Chairman. The Commission was referred two bills this year. As Senator Surville reminded me, the Commission certainly has other bills referred in previous years that it has not finished its work on. But the two bills sent during the 22 session, HB 240 by Delegate Dawn Adams. That bill would require the state health plan to offer an insulin discount program that allows individuals to purchase insulin at a discounted post-rebate price. The bill requires the discount program to allow the participant to purchase the insulin, as well as provide an electronic card, provide information about pharmacies that honor the discount, and provide instructions on how to get reimbursed from the participant's carrier. Additionally, the bill requires carriers to set a cost-sharing payment for insulin that is an amount that does not exceed $30 per 30-day supply of the prescription insulin drug unless the carrier covers at least one prescription drug for the treatment of insulin drug, the treatment of diabetes in each therapy category under the lowest tier of drugs, or guarantees that a covered person is not required to pay more out of pocket for the prescription insulin than the covered person would pay under the insulin discount program run by the state plan. The current law sets the insulin cost-sharing cap at $50 per 30-day supply. The second bill that you all referred, HB 477 by Delegate Austin, it prohibits a carrier from imposing on any person receiving coverage for prostate cancer screening any deductible, co-insurance, co-payment, or other cost-sharing requirement.
Are there any comments, questions, any approach that we should be taking on these bills? So,
Mr. Chairman.
yes. Senator Searle.
So would a motion be in order to have us do what, like a tier 1 review on this or something like that? Is that,
Yeah, that would make sense, so, yeah.
okay, so I'd make that motion.
Second.
All right, there's a motion and a second to have Tier 1 review. These, which is sort of the step 1, and then if, once we get the information back on that, then we would be able to decide sort of whether we go into step 2 or any other action that could be taken. Any kind of further comments on that? All right, can you call the roll?
Senator Surville?
Aye.
Senator Ware? Delegate Ware?
Aye.
Delegate Byron?
Aye.
Delegate McNamara?
Aye.
Delegate Sullivan?
Aye.
Senator Barker?
Aye.
Ayes 7, no 0.
All right, thank you. That motion passes. All right, now we will do a little presentation here on options for the new essential health benefits benchmark plan, maybe making some changes to the existing health benefits benchmark plan that we have that we've established. So we'll call on the Bureau of Insurance to present on that. So.
All right. Good morning, Mr. Chairman, members of the committee, commission. My name is Julie Blauvelt, and I'm with the Bureau of Insurance, Deputy Commissioner there. I'm going to be presenting the study that the Bureau did on essential health benefits, and I'm also going to include the actuaries, our consulting actuaries. They'll be picking up part of the presentation as we go.
Okay.
Just a little overview of what we're going to go over is the study that we did. We'll look at what are the groups of people that are affected by the essential health benefits and a change that would be made to the essential health benefits. The actuaries will talk about the federal requirements for changing essential health benefits for a state. The actuaries in the report compared Virginia's benchmark plan with that of our neighboring states, and they also compared our benchmark plan with states that have recently made a change to their essential health benefits. We're going to look at the cost of a few benefits that the Bureau had information on to do a quick estimate, and so that you can see that information. And we're going to talk about some considerations that the Commission may want to think about when selecting a new EHB or, in thinking down the road about whether an EHB needs to be changed and the timeline for that to happen.
All right. Proceed.
Okay. So as we were directed by the budget bill from this past session, the Bureau of Insurance did study and analyze information for a possible change to Virginia's essential health benefits benchmark plan. You may recall from the last session that there was quite a lot of discussion about new information that the Bureau had received from CMS about state mandates and any state mandates that come into play after 2011, the state would have to defray the cost for. So right. CMS did make clear to us and to other states that if new benefits wanted to be mandated by the state for the population that's affected by the requirement for essential health benefits, then the way to make a change for their benefits is to change the essential health benefits benchmark plan. Because anytime you mandate anything now, since the ACA, then the state's going to have to defray the cost of those benefits. Right. And these are affected, the plans that are affected and the plans where we would have to defray for are qualified health plans, and those are plans that are in the individual and small group market that are sold through the exchange. But CMS also told us you can't It's discriminatory to segment the individual and the small group market and say a certain set of benefits applies to the plan sold on the exchange versus off the exchange. So this is where we got around to doing this study to look at what changes we may want to make to the benchmark plan. And I will add that to make a change to the benchmark plan, this is talking about way in advance. So we're looking at a change. The first we could change our benchmark plan would be for the year 2025. And we would need to submit the application by May of next year to change it by then. And the study did not use any state funding because the Bureau of Insurance had applied for a federal grant to do this study beforehand.
Okay.
So this slide just shows the sliver of the population that is affected by essential health benefits. It's basically the people who have comprehensive health care coverage under the ACA in the individual and the small group markets. And those are the ones where they're required to, their coverage is required to provide the essential health benefits. And now I am going to turn it over to Richard Cadwell, I believe, with NovaRest, who is our consulting actuary with the Bureau, to proceed through a few of the other slides.
Okay.
Hello, can you hear me?
Yes.
All right, awesome.
I'm sorry,
Wait,
Richard.
Wait.
I'm sorry. That
Delegate
6%,
Sullivan.
that sliver you talked about, how many people is that?
I'm sorry. So the total Virginia population is about 8.5 million. That represents about 560,000 individuals.
Thank you. Thank you, Mr. Chairman.
Sorry, Richard, go ahead.
All right. Thank you, Deputy Commissioner and members of the Commission. My name is Richard Cadwell, and I'm a Associate Actuary with NovaRest Consulting. I've also got a couple other members of NovaRest on the line for any questions that you may have. So I can't really see how the slideshow is progressing. So I'm assuming you're on slide number 5 now, which is the federal rules for, that allow the state to select their EHB benchmark plan. So they really give you 3 options. The first option being you can select an EHB benchmark plan from another state that was used in the 2017 plan year. These are all really tied to the 2 of the options are really tied to that 2017 plan year. So you can select another state's EHB benchmark plan. The second option you have is you can actually take pieces of that other state's EHB benchmark plan. So you can take the EHB categories without taking the entire benchmark plan. And option 3 would be that you can select an entire set of benefits that would become the state's new EHB benchmark plan, which is what we've considered in these studies. We haven't looked at taking anything from another state. It's really more about adding more benefits to the current EHB benchmark plan. So on the next slide, we start talking about the federal requirements for an EHB benchmark plan. And there are 4 benefits that are specifically noted as not being able to be an EHB. So even if these were covered by the plan that was selected as an EHB benchmark plan, they would only be optional benefits. They would not be able to be fulfilled and called EHBs. So these 4 benefits would be routine non-pediatric dental services, routine non-pediatric eye exam services, long-term custodial nursing home care benefits, and non-medically necessary orthodontia. So that we would not be able to add those benefits to the EHB benchmark plan. On the next slide, we have some additional federal requirements, the first of which is the scope of benefits provided must be equal to or greater than a typical employer plan. We believe we're proposing to add benefits to a current EHB plan which satisfies this requirement. So the benefits we've considered adding will meet this requirement. And the second requirement is that the total benefits do not exceed the generosity of the most generous plan among the plans that were considered in 2017. So when the EHB benchmark plan was selected in 2017, we looked at a set of plans. I believe there was 9 of them. And so Novarest went in and we determined that the federal employee health benefits plan from Blue Cross and Blue Shield was the richest of the plans that were considered. And so when we take the value of that federal employee health benefits plan and compare that to the current EHB benchmark plan, we estimate that the value of the federal health benefit plan is $2.56 per member per month. It has that much more value than the current EHB benchmark plan. So that tells you how much in additional benefits that you could add to the EHB benchmark plan. On the next slide, we look at a few EHB additions, and these are benefits where the Virginia Bureau had some existing studies that they had done on the cost of these. So we were able to leverage that information to come up with these estimates, but these are very preliminary estimates. So Novarest would need some additional information and time to put together our estimates of what these are. But this is based on prior Virginia work, which we don't feel is unreasonable. And so the benefits that are considered here in total is 87 cents per member per month. And if you remember on the prior slide, you have about $2.56 per member per month of room. So we could easily add these benefits if that's what we're interested in doing. So these 4 benefits that we consider, the first is an oral enteral formula. So currently the Virginia benchmark plan does offer medically necessary enteral formula. So things like tube feeding, that would be currently covered. So what this benefit would add is an oral formula that is not necessarily necessary to sustain life, but is a critical component of that. So this is an expansion of that benefit. We also have donor breast milk. We have enhanced prosthetics. So this is another one where currently the Virginia benchmark plan does cover medically necessary prosthetics. And so this is looking at the more advanced prosthetics, which would improve quality of life. And then we also have hearing aids. So those are the 4 benefits where we were able to leverage some of the Bureau's prior studies. We also did a study, and this is on the next slide, where we looked at the states and jurisdictions surrounding Virginia to see if there were any benefits where we would say Virginia was an outlier in terms of not covering something. And what we found is 3 benefits that were covered by a majority of states, but are not covered in Virginia, at least to the same extent. So those would be oral surgery, so removal of impacted teeth, bariatric surgery, and hearing aids for minors. So again, hearing aids was one that we did look at some prior information that the BOI had put together. And then the other piece that we looked at is other states, and this is on the next slide, other states that had already taken the steps to update their EHB benchmark plan. And we looked at what did they add and how did that compare to Virginia's current EHB benchmark plan. So the benefits that were added by other states that were not covered by the Virginia EHB benchmark plan would be acupuncture, artery calcification testing, and weight loss programs. And
just a minute here.
Yes.
Has a question.
Byron.
Byron. Okay.
Yes, that's okay. You keep mentioning other states. Is there somewhere that we have information that refers to what these other states are?
Yes. I believe you have do you have a copy of the studies in front of you? No?
No, we do not.
Okay. In our full studies, we have a grid in there which gives you exactly which states these benefits came from and more of a description of that. And we have a grid of all the surrounding states and jurisdictions we considered, and then we also point to the states that had updated their EHB benchmark plans, which would be plans like Oregon and New Mexico, Colorado, Illinois, things like that, or states like that.
Mr. Chairman.
Yes.
So
Senator
you
Byron.
didn't take into consideration bordering states or states similar to Virginia's plans?
We did. We did. We did an analysis of all the bordering states and jurisdictions. That was the first part of our study. And that's where we determined that the Virginia EHB benchmark plan did not cover the oral surgery, bariatric surgery, and hearing aids for minors. Those are benefits that are covered in the surrounding bordering states and jurisdictions.
Last question. Does your
Yes.
study, the complete study, show more detail on what the benefits, for example, are for the hearing aids? Like, you're talking 50% of cost, or does it go into detail?
It doesn't go into more detail on what the actual benefit is, other than like surrounding states looking at covering hearing aid benefits for minors. So it would say like under age 19 or 22 or whatever they define that cutoff as. We don't go into description as to exactly what those benefits are, though.
Thank you.
All right, let me just ask one question, picking up on the hearing aids that you talked about there. Is there any effect of the federal action that's been taken to allow hearing aids to be sold without having a physician having recommended that? So.
We have not considered that in our estimate. The preliminary estimates that we've provided in these slides were based on prior work that had been done by the Virginia BOI. And so that work was done prior to this over-the-counter discussion. So we would take that into consideration if we move forward, and Novarest would perform their own estimates on that.
All right, thank you. Continue now.
Okay, I think at this point I'm going to pass it back to Deputy Commissioner Blauvelt.
Okay. So even though the path to add benefits to individual and small group markets is to choose or to change the benchmark plan instead of state mandates. If any state mandates have been passed since 2011, even if they are included in the Essential Health Benefits Benchmark Plan, the state would still have to defray the cost if that mandate is still there and still would apply to qualified health plans. So, for example, an example would be the oral enteral formula requirement, because that is a mandate there that would apply to QHPs, even though there was some saving language that was passed last session to allow QHPs to not have to include a state mandate if it wasn't EHB. But if it was made to be EHB, then it would need to be included. The state would have to defray the cost, so something would need to be changed about that mandate if the state did not want to defray the cost of this particular benefit. And there would be time to do that because, like I said, the benchmark plan wouldn't be effective until 2025, so there would be time to make whatever legislative changes once the benchmark plan is set.
All right, thank you.
All right, so looking at the authority to select the essential health benefits, Virginia, like most states, doesn't have really any clarifying statute or laws to say who is in charge of making the selection for the Essential Health Benefit Benchmark Plan. So one of the things that Virginia may wish to do is to make that clear who chooses. The benchmark plan that's in effect now and the original benchmark plan were both chosen by the governor with assistance from the Health and Human Resources Secretary. Those were choices that it was the default plan that was chosen, so if states didn't make a choice, we basically got the benchmark plan that we would have gotten. But there was some research leading up to those benchmark plan choices, and there were points in time where the federal government said states, need to set a benchmark plan, and then in 2017 or for 2017, the federal government said that states needed to reselect a benchmark plan or it would be defaulted. We're in a little different time period now where the federal government isn't requiring states to change their benchmark plan. So it's just up to states to make a change whenever they feel a change is needed. And the General Assembly did provide, or in establishing the Health Insurance Reform Commission back in 2013, they gave the authority for the HIRC to recommend health benefits that should be included in EHB. So, you could take that as some direction that HIRC may make a choice. And federal rules don't specify who in the state is required to make a choice.
Okay. Thank you.
So this just talks about a little bit what I was just talking about. That's some suggestions for states to stay on top of their benchmark plan and how it's meeting the needs of the residents is first to make sure that it's clear who's in charge of updating the benchmark plan and selecting the benchmark plan. Other things that the state may want to do is to set up stakeholder groups, working groups that are made up of diverse groups and interests, and watch out for changes that may be necessary in the benchmark plan. They're using a data-driven approach. There are a lot of state entities that could be helpful in the process. The Bureau of Insurance could be helpful. The exchange could be helpful. The public health departments or academic and research institutions could also be helpful in providing data that may help to decide what benefits should be included in the benchmark plan. And a coordinated approach, there may be some state initiatives, state studies that are going on that the group could link into and try to pool resources to figure out what would be the best approach for a benchmark plan. Okay, so this is the timeline. If it's determined that we do want to do a new essential health benefits benchmark plan for the year 2025, in the next couple weeks is really when Virginia, I guess, would need to make a decision on whether we will be going forward with a benchmark plan, a new benchmark plan for 2025, and who is going to make that decision on what benefits to for the actuaries to center on to do a deeper dive. Because what would happen then is when those benefits are chosen in January or in December, our actuaries would survey the health carriers, do a deeper dive on it, do a presentation back to the deciding entity on what they found, the cost, more in-depth cost estimates of what the changes would entail. And really by mid-February, there would need to be a pretty final decision on what the benchmark would look like for 2025. because there is a required public comment period. The Bureau of Insurance could handle the public comment period. This commission could handle the public comment period. And then usually before the public comment period, states present what they think is their final benchmark plan. They get the public comments, and then after those public comments, make any changes, and then submit an application. May 3rd of 2023 is the deadline for submitting application for the 2025 benchmark plan. Now, that's not to say that if we miss that deadline, we won't be able to change our benchmark plan, because it can happen in at any subsequent year. A change could be made by the beginning of May of the 2 years prior.
Mr.
right.
Chairman,
Yes, Delegate Ware.
Surville.
Oh, Sorreville.
Sorry, I have a couple of questions. So I'm just trying to understand how the deciding entity is figured out. So I understand under current Virginia law, I guess there must be ambiguity about who decides the benchmark plan. And so I don't know, is there a code section, or is there a reg or something, or is it in the absence of state law, federal law says, here's who decides, or in the absence of a statute or the budget, somebody has to decide, so the governor just stepped in and made a decision? I'm trying to understand like how we got to where we are, what the current framework is.
Yes, really, no, there is no federal requirement on who decides. There's no federal fallback if the state doesn't have a law. And yeah, I think there are several entities that could be recognized. The governor certainly one. A commission like this could be one. And the section 30-342, the section that established the Health Insurance Reform Commission, says that this group has the authority to recommend benefits to be added to the essential health benefits. Doesn't say, specifically that they are to set the benchmark plan, but I think it's pretty close. So legislation could be set to say exactly who is in charge of setting the benchmark plan.
Mr. Chairman.
Yes, Senator Sorreville.
Thanks. So, I don't know, when I heard the word recommend, that to me doesn't mean decide necessarily, just sort of means we give advice, but it also strikes me that, the Bureau of Insurance, they're the ones that regulate health insurance and look at plans and decide who's in compliance with law with all that. Isn't that also in theory, I'm not sure, I see Mr. White squirming over there, whether, couldn't that also be a place that could, obviously we could delegate it by statute, but in the absence of a statute, is there some reason why it doesn't necessarily fall to them or not?
I would just say, in general, the Bureau of Insurance is not, a policy-making entity. So I guess we wouldn't normally see that as something that would be our decision to set that policy. But certainly, like you say, if we're directed to do so in the statute, then that would be different.
Mr. Chairman, further question?
Yes, Senator Sorreville.
Thanks. But there's other divisions of the SCC that sort of make policy. They issue regulations and rules in the absence of us making rules. And so it seems to me that the SCC has at least done that in other areas. I'm not quite as familiar with insurance as I am, for example, the Bureau of Financial Institutions or something like that. But it just seems to me that's another possible way to look at it in the absence of any specific authority, although given the time frame we're working off where somebody has to make a decision by February, it's not really clear to me. I'm sort of trying to think through what workable options there are, and how to decide who the decider is.
Right.
We're certainly not, I doubt, unless we had an epiphany between branches in the governor's office as to how to pass a law by February and get it signed, which I don't think is very realistic, but in theory it could happen, in theory, if everybody had a moment of bipartisan glory or something, but
Delegate Byron.
Yeah, let me just add to the discussion, and maybe we can, by discussing it, we can figure out what we're doing too, because I have a few questions as well. So, November 30th, what's today, November the what?
15.
15th, yes, that came upon us very quickly.
Yes.
And I don't understand that, that delay in itself, but, so if we don't make a change to the plan, and it sounds like until we establish something possibly in code, we can either come back every year to review the EHB, or we can determine we're going to do it every 4 years, 3 years, whatever. So if we don't do anything particular right now, is the only thing that would be affected by it be the formula that we passed? By not adding that on, that becomes a liability of the state? Is that?
No, that only becomes a liability if it's made essential health benefits. Because right now, in the last session, I call it a saving statute was passed to allow qualified health plans to not have to provide state mandates that are in addition to EHB. So as long as the full oral enteral nutrition benefit is not EHB, plans can choose to provide it or not provide it, and the state does not have to defray the cost. But if we were to make that what was in that mandate, that state mandate, if we were to make that part of the EHB, or make it EHB, QHPs would not have a choice. They would have to provide it, and if that statute was still there, then the state would have to defray.
If I could continue, so we were always considered to have a fairly rich EHB, or we thought we did for Virginia. So some of the other states and what they're doing may be good for them, but it certainly wasn't a choice that we made at the time. So if we don't do any changes, we would continue with the plan that we have been using,
Yes.
correct?
Correct.
The other change, if you change who is the decision maker in changing the EHB, does that have to be done by application, or is that just part of
No.
our code?
That would just be part of our code, yes.
Okay.
And we don't have to establish who's the decision maker, but
I would feel
So-
that we might want to.
without it, it's not clear.
There are only 8 of us here, but we do carry some weight. So.
Yeah, and the first time the Bureau brings back the wrong decision, I can imagine there may be a change the following year. So that's probably what would happen if it got turned over to the Bureau, because the lawmakers tend to think they represent the population and bring their thoughts and decisions down based on that. So I'll let the discussion continue with Delegate Sullivan. I guess he had a question.
Yes, Delegate Ware, or Delegate Sullivan. Then
Thank you, Mr. Chair.
and
So
Delegate Ware.
I'm still stuck on this timeline. Did I hear you say that if we meaning Virginia does nothing by
May 3rd.
May, whatever,
May 3rd.
we lose any chance to make any change by 2025?
That's correct.
And
yes.
so we'd be looking at 2026?
Correct.
At the earliest?
Right. Right. And it's really if we don't do anything by, say,
Right.
December, because the process really the actuaries need to start surveying the plans and have the benefits, that are being considered for the essential health benefits. They need to get that information in order to make application.
Mr. Chairman?
Yes, Delegate
So
Sullivan.
what you're suggesting, ma'am, is the process needs to start much earlier than May, but a final decision would have to be made by May.
Right.
Application
Yes.
submitted. Okay. All right, Delegate Ware.
Thank you, Mr. Chairman. And I, too, have a series of thoughts, questions, and observations. It does seem to me that this is a policy decision. We, as a legislature, or even a designated commission of the legislature, do not have the collective expertise to set up a hierarchy of goods for add-ons, make assessments of the monthly costs of the benefits, and so on. it would seem to me that the appropriate thing, and I don't know if, I'm hearing sort of conflicting points on this, the way to go would be for us to delegate this authority to the executive, and allow the administration to make the decision because they have the requisite people who can make those assessments as to the value of those benefits, as to whether they should be included for the EHB plan. So I guess that's where I'm thinking at this point, even though I can see the Bureau of Insurance has certain qualifications to do it.
Yeah, I mean, we've already had the experience through this and even the predecessor entity to HERT to analyze the cost and what the impact would be of adding a required mandated benefit, whether it was just when we did the mandated benefits or whether it would be now under this situation being the essential health benefit plan that we would have put in place here. So we can get information that I think can help us make a decision on things. The question is then, how would we structure that to be able to make that decision? It could be through legislation, it could be through something incorporated in the budget, but and it could be recommendations coming from HERT, and all of those, provide opportunity for both the governor as well as the General Assembly to be involved in this process. And I think that's probably the best way to do it, that we need to be able to work together to reach a consensus on terms of what types of benefits should be added to the essential health benefits here.
So, Mr. Chairman, if I understand you correctly, what you're saying is that we should make a recommendation that can then be reviewed by other appropriate...
There are a lot of options here, but I think if we're going to do anything for 2025, and we don't have to do it for 2025, we could do it for 2026 if we want to get everything all laid out well in advance of when we would have to have that its submission for 2026, because that would not be till would not occur by May 3rd of 2023. It would occur somewhere around May 3rd of 2024.
Gotcha.
To be able to have that, and then the carriers would be able to calculate what they what their plans would be and how much they would cost in 2025 in that point, and then would go into effect at January 1 of 2026.
Well, with the proviso of the added 12 months, I think I'm on board with you.
Yes, yeah.
Mr. Chairman.
Yeah. Delegate McNamara and then Senator Sorbo.
Thank you, Mr. Chairman. My direct question, if I could. So if the slides aren't numbered, but if I look at some of the potential benefits additions, it refers to per person, per month cost if we looked at all four of them in there together, and I'm just going to call it $1 a month. And again, using fuzzy math, I'm going to call it $10 a year. And as I understand it, we need to subsidize the private carriers for the cost of providing this benefit, which would be the other 94% of the Commonwealth.
Mr. Chair.
Yes.
No, there would be no subsidization in just looking at essential health benefits. Essential health benefits are what the ACA set as for the individual and the small group markets to have to provide that benefit. If a state makes mandates outside of setting the benchmark plan, so passes a law and makes a mandate, then CMS has said that the state has to subsidize that. But if you're only changing the benchmark plan and you're staying within the parameters of what the actuary described that we have to stay within, then the state does not have to subsidize any of that.
So we would...
Yes, go ahead.
If we may, so we would take, it would be, the other 80 or 94% would be $80 to $100 million that then the private insurers would have to then split up among their subscribers, no?
Mr.
Yep.
Chairman, can I ask a
What-
question, try and clarify that?
Senator Searle, then Delegate Byron.
With regard to the other 94%, we're talking about Medicare, Medicaid,
Okay.
employer self-insured ERISA, right? So when we're talking about mandating benefits, we're only talking about people that have state-regulated health insurance policies, which is what percent of the market? Like,
6%. Well, then for the individual and small group, just 6%.
No, but what
Large
about-
group is larger, another 12%.
So
So,
it's
out-
18.
what?
so whenever we mandate a benefit,
18%.
we're talking about, you're saying no more than 18% of the market?
Right.
Right, so that,
Okay.
further question, Mr. Chairman?
Senator Searle.
So that additional cost that we're mandating obviously doesn't apply to people that are insured by the United States military or the federal government or ERISA self-insured or Medicare, Medicaid, et cetera, right?
That's correct, yes.
Right, okay. I have another question whenever you want to come back to me.
All right, Delegate Byron.
Just going back to trying to decide how this is all going to play in the future, just a few comments, because I think I'm following the same path as the chair. The HERC was formed in 2012. So it's been 10 years that we've been operating on making recommendations on whether or not, with the Bureau of Insurance's help and actuarial information, deciding on whether or not we were going to change things within the plan and what potential impact would be on our small business group and those that would have to pay those costs. So we have actually done that already. I think I would have grave concerns just turning it over to an administration that's focused on a lot of other things without this input. And when we have a mandate that we come back with that HERC recommended going forward with, a bill was required for that. So I would imagine that we would use that same system for that that's exactly what you were saying, right? That a bill would go forward with the changes that were decided on for the recommendations, and that's going to go through a process. And the governor's going to get a chance at it, and the public somewhat by getting in touch with everybody as well. So that would be a pretty extensive way to go through it, as long as we weren't doing it every year. So that's where I would tend to be leaning in that direction. But I think the most important thing is that we still decide if there's a dire need to have something done by May 3rd and what that would be, that would make us feel like we had to get a change
Well, just
done.
to comment real quick, and then I'll get this Senator Searle. Clearly, I think that we need to keep open the option of saying, if at some point, and we're trying to see whether we could get something that would be able to go in place for 2025, and if it became apparent that there was not enough consensus or whatever to be able to get to that point, what we could do is then postpone until 2026 and have it and continue the process during the next year. So, Senator Searle.
Thank you, Mr. Chairman. So just so I'm clear about this process and the lack of authority or whatever, is there anything prohibiting the governor from just coming in and saying, I've picked a new benchmark plan tomorrow and that's what it's going to be, and then we're in a reactive posture instead of in a proactive posture?
No, I'm not aware of anything to prohibit that. The governor could pick the benchmark plan, and that information would still have to be submitted and approved by CMS.
Right. Okay. And further question, Mr. Chairman? Right.
Yeah.
Another question?
Yes, Senator Searle.
So, does somebody out there have a chart, a survey of how they do this in other states? And have you ever seen one?
All right.
Man, maybe NCSL could probably give us something as my guess too, but that doesn't sound like you've looked at it.
I don't know that, I know that most states don't have a process laid out of who is in charge of selecting the benchmark plan. Probably in other states, it is done by the Department of Insurance because they're in a little different posture than we are in Virginia. But I don't know if our actuaries can comment on that, if they know of any information out there that gives how other states select their benchmark plan.
Okay.
I do think it varies by state. We did work with one other state on, actually two other states on changing their EHB benchmark plan, and I believe it was the Department of Insurance that made the decision.
Okay, thanks.
All right. Sure.
Mr. Chairman.
Delegate.
This may be a question for you, I guess, Mr. Chairman. So it looks to me, I've been reading the enabling statute for this body,
Right.
that we clearly have the authority to make recommendations and have, and come up with those recommendations as, on this sort of thing, and we can continue to move forward. In other words, we're not at a stopping place today.
Right.
We should,
Right.
this chart, which I guess is now still up there,
Yeah.
we ought to try to hit these deadlines and keep moving forward with the analysis and see what happens in the next session with respect to potential legislation. Is that what
Right.
you're suggesting, Mr. Chairman?
Yes, and I think that we may want to have another meeting well in advance of the session.
There's not much left well in advance
I
of
know,
sessions.
yeah.
Someone
Well,
tells me we're looking at during
yeah.
session, but.
Yeah, a lot of it, we would have to do it during, some of it during session, but we could have another meeting in the HERC and sort of talk through in more detail what we're looking at here, and have staff work with us to be able to, and Bureau of Insurance to work with some options in terms of how we could structure it and get it to where we can have a consideration, during the first part of 2023, and potentially either be on target to get something done by May 3rd and submitted, or to postpone until 2026. Delegate Pyre.
Yes, would it be appropriate to have Doug Gray speak to us for a moment, since he represents the health plans, and tell us what he knows?
When in doubt, call Doug, so.
I'm Doug Gray, Executive Director of the Virginia Association of Health Plans. I just wanted to share a couple observations with you. One is, in other states, the insurance department's under the executive, and that's why it's
Right.
written the way it is under the federal law. Here, we've always had the State Corporation Commission, and so it really reports to the legislature. So, I think, just generally from an observation perspective, I think it's your call as the HERC and as the legislature to move the ball forward. It doesn't mean that you don't want the administration's advice. It's just, as the structure of Virginia's government goes in its history and approach, that's the history of how it is and why it is here and why it's different than what the federal rule says. So that's just the first observation. Second thing is, I think the analysis is analysis of statutes, not of coverage. And that's important because we've dealt with a number of these items and we've changed the legislative language and we've gone back and examined what's out there in the coverage. So for example, with the formula mandate that we undid last year because there had to be a defrayal, we basically changed the statute language, but the coverage didn't change. The coverage had already moved to add the more expansive benefit. So when you're trying to do an analysis of whether you want to add something or not, you really need to look at the coverage in the market rather than the statute itself, because they're two different things. And that helps you understand whether it's necessary or not necessary. So that's another kind of step in the process. For example, with prosthetics, we added medical necessity so that more advanced things would be covered. But we didn't add all things being covered. And that's not out of line. That's in line with the other states. So, again, we've made adjustments to our statutes. If you look at the charts in the study of the four topics, prosthetics, hearing aids, formula, and donor breast milk, none of them are covered in Virginia, D.C., Delaware, New York, Maryland, Tennessee, North Carolina, and West Virginia. So in our region, none of them. So we're not out of step under their analysis. Now, what they've really told you is the way these rules work, because you considered something that had a higher actuarial value, you basically have 2% that you can play with and not get charged for. That's basically what they said. Now, to me, that's a really dangerous way to start a conversation. It's like, go ahead. I mean, that's really what it says. And that's truly what the federal rules permit you to do. But it doesn't tell you which one to pick or why to pick or what you're going to get for it. So if you don't understand what's in the coverage now, you'll pick covering something that's already covered, and that will get you absolutely nothing. And so that's kind of the challenge with this process. It's not an easy process, and I'm not criticizing anybody around the report. One of the challenges is, when you do an actuarial estimate, is it for the 6% or is it for the 6% and the large group that you have to apply it to as well? Because you do have to apply it to the large group if you apply it to individual and small group. So that's an additional cost for the large group fully insured customer that is not being captured in this discussion. And it should be captured in the discussion so that you do it, with an open mind. Who writes the details of the coverage is a pretty relevant question. Let's say you picked any list of 2 or 3 things. Our Bible is to go to the statute. That's what describes what we do, right? If you were to include a new item to be covered, where are the details? We got to have a place to refer to. So I don't know who writes this under this process, and I'm not sure anybody else does. And frankly, this is the first time this process has been considered, and I don't think it's been done frequently in other states. It's done in a few times in other states, and they've tried to update their basic needs. So anyway, those are the observations. I mean, I really think you got to proceed carefully. Now, could you do a bill or some budget language that says we want to move forward and we're going to look at these things and then try to come to a consensus later? You could. But you'd have to know what things are worth pursuing. Hearing aids, for example. Hearing aids are not covered in any of these surrounding states, and they're now over the counter. So doing a large dollar amount benefit for everyone doesn't make sense anymore. It's a different environment than it was before they became over the counter. So those are items that you've got to think your way through. So I don't really have feedback from my plans on the report or a specific position on any of the items. Those are just observations about the process and how we've worked it to this point and how to work it going forward. So thanks.
All right, thank you. Wait, one quick thing. Don't run away yet. You were almost escaped, but no, if we pick something out of these 4 or all 4 of those, or look at the other 3 that have been recommended, or anything else that could be added to it, we can have the actuaries work on in terms of what it would cost to provide that. Do they have information then, or is there information available to us that would help us understand what % of the market already is covered, for the things that we're considering, because it's in the plans that the carriers are providing. So
yes, we can. Every plan has to lay out what's covered, but remember that's already driven by your previous choice. You picked in. Well, no, we can't. No plan can go below what the previous choice was, and we've of course updated several of the benefits and statutes. So anything that was in question has to meet that as well. So we already know kind of where we're at. That's why I wouldn't, for example, recommend hearing aids or the formula because they're already being covered. Same thing with the prosthetics. They're already being covered at the appropriate level. What they're saying here is just an open-ended, and I don't know how that can be done from an administrative perspective. How do you know what you're responsible for? Right. I mean, it's not an easy thing to do in theory. It has to. That's why it's complicated and it needs to be written down.
All right. Mr. Chairman, could I ask Mr. Gray a question?
Certainly, Delegate Sullivan.
Mr. Gray, I'm interested in the hearing aid issue and whether the federal decision to make them over the counter changes our analysis somehow. There are lots of things that get covered by insurance even though they're over the counter. Isn't that right?
Well, not many,
Well,
but some.
for instance, if I need a wheelchair,
Well,
right,
that's
to
not,
walk.
that's not over the counter. That's called DME.
well,
And it's
I don't need a
sep-
prescription to get a wheelchair.
Well, you might actually have to
I
meet
could
some.
get a prescription, but I don't need
Well,
one. When
you-
I walk into my,
You need to meet some requirements to
fair
need
enough.
one.
Fair enough. Well,
Yeah.
so my question to you is this. In your view, does the fact that hearing aids are now over the counter disqualify them from being part of our EBP?
Mr. Chairman, no, it doesn't disqualify them. But what it does do is bring into question whether setting one large dollar amount for all beneficiaries for hearing loss makes sense anymore. The price was artificially high because it was only available through a very tiny market with a review by an audiologist. That is not the case anymore. Does that mean that somebody doesn't want to use an audiologist or might not need a more sophisticated hearing aid? No. There are cases in which they will. But if you look at Medicare, for example, they don't have just a blanket coverage for hearing aids. Now, do plans cover them on their own? Yes, they do.
Okay. Thank you. Thank you, Mr. Griffin.
All right, Delegate Byron.
Yeah, before you leave, I don't know that I have a specific question for you, but when you look at some of these on paper, the thing that I recall from so many years of looking at mandates, an example is the hearing aids. There are so many things that come before us that sound absolutely fabulous. You know, we just want to fix everything. And then you have self-insured plans that don't include it, which is a very large part of the population. I had someone bring a bill to us years ago, and it was a grandmother that wanted hearing aids for her grandchildren. And taking into consideration how many do you cover when they lose them, destroy them, jump on them, or something happens to them. You know, my husband lost two he had to replace from wearing a mask and taking the mask off, and the hearing aid goes with it. You don't know it. So, you know, you have to lay out the details of all this, and then you have all these other plans that it's not even a part of their plan. So we also become where we're trying to provide it all, and it's just not possible either. So us reviewing those things is very critical, that we keep having our committee that can take a deeper dive and make sure we look at all the things that surround that coverage. That's what I would recommend.
Yeah. Mr. Chairman, it's not easy.
No.
And I think the problem is when you get a study that says you can spend an extra 2% and not have to pay for it, that it feels like you've gotten a good deal. But it's really not, free. There is nothing free. I mean, if you add these things, the people in the large group are going to have to pay for them. And you have to be detailed about what it is that you want covered. You can't just say, we now cover X. I mean, this is the challenge we had with breast milk.
Right.
There is no regulation of donated breast milk centers at this point.
Right.
And then that's why they're having trouble with coverage. None of the other states in our area, they don't provide that coverage. Will they someday? Will we get that regulatory structure? Sure, we could get that regulatory structure in place. But you can't just say it's now covered and then expect us to be able to figure it out. I mean, it doesn't work like that. So you have to work your way through the details and understand the implications one step at a time. So anyway, thank you.
All right, thank you. Any other questions or comments? Anyone else want to weigh in? Delegate Ware.
Mr. Chairman, I have looked at the NCSL website as to who the decision makers are, and it is just as far all over the map as we might guess. Commissions, legislative commissions, bureaus of insurance,
Right.
the administration, it's
Right.
all over the map.
Okay. So, all right. Anybody else want to weigh in on the issues here or ask any more questions of whoever we could track down? So,
Yes, Mr. Chairman. So, November 29th, should we wonder if there's going to be a state body that's going to determine if an application is made, or do we do we assume that, do we know of a state body that's going to make a recommendation?
I
know,
think,
We could make a recommendation, obviously.
Oh, that's
Yeah.
just to
Yeah.
keep it moving
Yeah.
until,
Moving,
what
right,
is
right.
your, I mean, I know the May 3rd is a date, but
Right.
yes,
you have some other dates too, like
Right, there are
in
several.
December, they're supposed to analyze this, and
you're
Is
correct.
that-
There are
is-
several decision dates.
Nova Rest, are they part of continued, we're contracting with them with the grant you have? Is that what the situation?
Yes, it would fund the study for any detailed study in order to submit an application. I
Right.
think the grant does end August of next year, so.
All right. Yes, Senator Searle.
Thanks. So, Mr. Chair, it seems to me like there's two questions. One is what should the process be of getting to a conclusion? You know, assuming our current process is not particularly adequate, and having served in this body for about, a year and a half now, 2 years, something like that, I struggle trying to figure out, what to grant and who to deny or how to vote or whatever, as many of us, I think, up here do. So it seems to me anyways that that's one issue is the process. The second one is, I guess, who sort of starts the process of proposing a new benefit plan where we are right now. And it strikes me that on something like this, the more input from multiple levels, the better, but somebody needs to start the process. And, the way we usually do things is somebody proposes a bill and then we chew on it and the governor chews on it, whatever. It seems to me like either the Bureau of Insurance or the governor could propose something, the Bureau of Insurance could provide input on it, then we can look at it and decide if we like it or something like that. And maybe that's just one concept of a process.
Right.
But, and there's other people can deal with some public hearings, and there'll be public hearings before it ever gets here, and then people come yell at us if they want at the end. But it seems to me those are the two independent questions is what, do we like the process we have now? What should the process be? And then secondly, how does it start if we're going to start it? And, is there some way we can maybe sort of jumpstart a process in the meantime to sort of come into this new process we might create as we go through the legislative session maybe? So it seems to me that's kind of where we are, but maybe, I don't know if everybody else agrees with me, but.
Yeah, Delegate
Mr.
Sullivan.
Chairman. So again, I'm looking at our enabling statute, in paragraph 5. I'm glad you're here, Madam Chair. It says, upon request of the chairman of the House Committee on Labor and Commerce, now Commerce and Energy, we can assess proposed mandated benefits and providers and recommend whether, on the basis of such assessments, mandated benefits and providers be providers under health care plans offered through health benefit exchanges, outside benefit exchanges, neither or both. And I sort of assumed that's why we were here, that the committee in the House and the corresponding committee in the Senate had asked us to do this, and then we have in turn asked these fine people to keep that process moving. It sounds like we may have a decision point as to who makes the final call or how the final call is made, but that's something we can be working on over the next several months. From my perspective, we ought not stop the process now while we figure out that endpoint. We are entitled, or we are empowered to keep this process going, have the continued study, and then whenever we're able to reach a conclusion as to who gets to do what at the end, we'll have the information available to us. Does that make sense?
Well, I think if we like the process, and there seems to be some consensus around that I just need to take a deeper look at it, and the chair will as well, and make sure that it's clarifying, the language is clarifying enough that that there's no doubt about who is supposed to do which step. We really laid out and made changes a couple years ago to the different tiers as to how we're going to study things, and it may be that we need to have a little bit more detail about, the plan being, at some point, the plan being changed, what that is. And that's just with not taking much time to look at it, but I think it's the same thing you're saying, but saying that we need to take a look and see if there's a change that needs to be made, we need to do a bill this year. And then we can make sure we have that in place.
Yeah, and I would suggest that we, if we want to go forward and potentially be able to have something that could be in place by 2025, although it might not end up in that being resolved that quickly, that we take the approach that you're suggesting, look at the language that's there, try to figure out sort of what our role would be in the process in terms of initiating the gathering of information, and then how we would make the decisions as to what elements we would propose to be added to the essential health benefit plan, and work it through the process where through a bill or through the budget, one of those two, have something that the General Assembly would be proposing, and but that the governor would have action on it as well. And so, and the secretary, I'm sure, in that process is,
Mr.
to
Chairman?
say the least, yes.
Well, since I was going to ask the secretary whether he wants an opportunity to sort of weigh in on this.
No, this is fun. I'm not going to speak to your process, but
Right. 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 All right, thank you, thank you. Is there sort of a consensus as to that approach to start working on things? And we can work with staff and with the Bureau of Insurance and the secretary and whoever else, we want to bring into the process here, to put some options together and
Okay.
to meet as soon as we get past the Thanksgiving turkeys.
Okay.
Sometime after that. So to at least have something that would have us work on that process there. And what I would also say that at that point, we would need to take action to figure out what the role of what the actuaries would be looking at there.
Yes.
It seems to me that I can think there are the 4 items that were incorporated in what they've put together thus far. The 3 items that were listed as available in some states, but not in ours now. And we did have one other issue that we postponed waiting that had proposed a tier 1. We did had a tier 1 study related to in vitro fertilization. We did not go forward with a tier 2 because the conclusion was that if we did that, we would end up having to pay all the cost of it. And so, and there was a decision sort of implicit to look at sort of whether that would be something that could be incorporated in the essential health benefit. So those 8 items, at least, it would seem to me we ought to at least consider those to be something that the actuaries would provide us information on, and working with the Bureau of Insurance.
Okay.
Is that a reasonable approach on everything? Yes, Delegate Byron.
It seemed like there was a few more added in there that I'm not sure we even looked at yet.
No, what I'm saying is that these are ones we should look at before we move forward. I mean, there are 3 of these that haven't been looked at.
But for the May 3rd deadline is what you're saying?
Yeah, because this will allow the actuaries, any of those that we select for consideration, the actuaries would be doing their analysis on those. So we would have the information prior to, so that, and I think the
How long
expectation
did
is
it take to do this?
It would take if my understanding is that if we take action in early December or late November and move forward along this line, the actuaries could start the process and report back to us probably sometime in January, and then we could have a meeting during the legislative session to be able to, that would maybe relate specifically to any legislation that might be proposed, and have that be something that we could have handle in February, and that would give us time to do the public hearing process after that in advance of the May 3rd deadline.
Mr. Chairman, I must be misunderstanding something, because I thought that if we were going to somewhat be in charge of recommendations, that we were going to make a recommendation in the form of something to the body that would be in a bill. And you're saying we can still do a bill in February because we will have hit crossover by then?
No, I mean, we will have information coming out in January, so it's from the actuaries. But what we could do is basically have bills in that could be then, if they need to be amended through the process, to get that done there. And, and we would have a consistency in terms of how we try to approach things.
Okay. We're not making a decision on this today, right?
Well, we're not making any decision other than to come back again and start the process of making a decision. We don't have
Okay.
anything specific on the table right now, so.
Mr. Chairman, we're also making a decision not to put a stop to the ongoing analysis, right?
Right.
Right, so if I could, I'd like
Sure.
to ask our actuaries, if they're still on the line, if they would be able to analyze, do a deeper dive of the 4 benefits that we've already looked at, plus I believe an infertility benefit. Is that what you're referring to? And then the 3 other benefits, I wanted to make sure, so there were 2 slides that had
I guess he's talking about
3 other benefits. One was on surrounding jurisdictions, and one was states that have recently added to their EHB. I think one was hearing aids for minors, which is already being studied. Bariatric surgery, oral surgery, acupuncture, artery calcification testing, and weight loss programs.
I do the ones compared to the surrounding states.
What's that?
The 3 that he just had, oral surgery, bariatric.
Okay, that sounds fine.
And we're not
The surrounding states.
programs, are we?
Okay, if our actuaries are still on the line, would it be possible to do that deeper dive of 8 benefits, 4 that we've already looked at, but do a deeper dive, and then 4 others on the same timeline that we were looking at?
Yes, I believe that would be possible. Obviously, the sooner the better if we're trying to meet that January deadline, because as was brought up earlier, we really do want to get involvement with the carriers in the market to see what the current levels of coverage are,
Right.
and to do that analysis. So they would need time to look at their own coverage, and so that's also a piece. I do believe it is possible, though. Yes.
Okay.
What's that? Oh, yeah. Well, we can. Okay. Right. And then we get the information. Yeah.
We're not locking ourselves into
Yeah. No. Yeah. Okay. Yeah. Go ahead, Mr. Stevens.
All right, Doug wants me to clarify what we're starting with.
Let me just go ahead.
You want to go ahead?
So on some of these items, you passed legislation that we couldn't keep on the books because you didn't want to do the defrayal,
Right.
right?
That's
So that's a pretty simple standard. So for that, we did something, we took out some language on the formula issue because of the defrayal. So,
Okay.
if that's what you want to add, that language that's already passed the statute, back into the essential health benefit, that's a definable benefit, makes sense. You're doing it because you had to take that language off because you didn't want to pay the deferral. We had basically the same conversation with prosthetics. We changed the benefit language to say medically necessary, but I think we had trouble with applying it to the individual and small group market. So again, you passed the statute, but You didn't really apply it to individual and small group because you didn't want to do the defrayal. Both of those are things you could get around the defrayal by creating a new AHB with, and there's a clear standard for. You have not passed anything to do with breast milk, for example. You did pass a bill on hearing aids that never took effect.
Right.
I mean, you could use that as what you wanted to start with. At least it's a definable standard. But again, that passed prior to the change in the federal language. So, you know, what you're starting with has to be told if you want to figure out what it's going to cost. So those three things, you have something to start with. The others, I mean, for example, if you want to go down the road on trying to figure out in vitro, there are 50 different designs for in vitro. Different bills, different places, different things covered, different number of tries. You have no legislative record, nothing you've ever passed on it. I mean, it's still an idea, and that's it. So if you're trying to do this, you kind of have to have a bill that says, all right, these are the things we're going to add, you know, or something like that, and then we can work it through. But leaving it a blank slate will encourage everybody and their brother to add another item and another item. And I'm not sure that's what you're after.
All right. Mr. Stevens,
Thank you, Mr. Chair. I would point out there was an IVF bill referred to this commission that could be the beginnings of whatever's looked at. Just to clarify sort of what you all are doing, and please jump in if I'm incorrect, but you're determining today that an application will be made for a change to the EHB for 2025 in order for the Bureau to get started on their work, have the actuaries look into the benefits that you previously discussed, and then a final decision won't be made until during session. Concurrently with that, there may be bills to change the process, to codify the process by which EHB's the EHB benchmark plan is changed going forward.
Right.
Is that correct? That is the consensus right now of the commission?
I think there's a consensus. Is there a consensus? Yeah.
He just gave us something well.
Mr. Chair, Delegate Byron, I will restate, I'm saying that today you are determining that an application will be made for a change to the HB benchmark plan for 2025, and what benefits will be further explored. This is just in order to get the Bureau to start their process. They'll look at those benefits. You all will come back at some point in session to say yay or nay. Concurrently with that, there may be legislation codifying the process for changing the benchmark plan going forward.
I would say that based on some other things we heard, that we could probably even agree today on the oral enteral formula and the prosthetics to put that into the EHB and come to an agreement on that, and the administration of the changes to the essential health benefit plan, benchmark plan, administrative issues, and that we could probably come to an agreement without having, in case nothing else changes. That was what we were just talking about, what that Doug referred to, that we had already looked at those and changed the language in order to accommodate those two.
Okay, those two, because otherwise we were going to have to incur funding them.
Joe.
Yes, Delegate Mayor.
Thank you. I'm wondering if, from a process perspective, those two actions went through the committee process. We put boundaries around them. We identified, we basically created the benefit, and this is the definition of that benefit. Maybe if we codify, that's the process we go through, and then at that point, this body becomes almost, just a final approval authority for changing enhanced benefit plans, then, or the EHB, we can then, for this year, we say, we're going to look at the oral, the formula, we're going to look at the enhanced prosthetics because we have it defined. There may be some of these others that throughout the session, we go through it in a normal course without trying to rush things. And next year, if it passes through the General Assembly based on procedures we develop, then we come back here and next year we look at another change in enhanced benefit rather than trying to take these other actions outside of the legislative process and try to jam them into this year would be my suggestion. So we make our changes today. This is how we're going to change our EHB. That will take effect in 2025. And this session, we come up with procedures that is similar to the procedures that followed through on those particular 2 items. And we look at the other 2 or 3 or 4 or whatever items we wish to look at, let it go through the legislative process. At that point, then it would become a 2026 change if this body then approved it a year from now.
All right, is there consensus on that? Any objections to that approach?
Mr. Chairman?
Yes, Delegate Ware.
It seems to me there is a consensus developing about those 2 items to be added this year. I have some hesitation on doing an annual revision, even through this process, to our EHB. My suggestion would be something more like, and I'm going to put a number out there, it's not magic,
3 or 4.
but every 3 years we review the essential health benefits. And there may be something in federal statute, but I think that would give us a little time to be more, to get the comfort like we have already gotten with these 2.
All right.
Would be my suggestion.
Well, why don't we work on what that time frame would be, we should be here, so, but we don't have to decide that today. And we certainly can codify it at 2 years, 3 years, 4 years, whatever, there, so. All right, anything else anybody has to say, weigh in on this, so.
If I may, I just wanted
Yes.
to clarify. So are we moving forward with the analysis on just those 2 benefits that we talked about now instead of the 8?
That
They already
seems-
did it.
That seems to be the
Okay.
consensus here, so.
Okay, thank you.
All right. Anything else?
I think I had a review slide, but I think that we've covered everything in this
Yeah.
discussion.
Okay.
Thank you.
Well, that's good, if we thought of everything already, so. All right. All right, we've had discussion. If there's nothing further, we will move on to public comment.
Yes, Mr. Chairman and members of the committee, Bob Bradshaw, excuse me, with the Independent Insurance Agents of Virginia. I encourage my staff to wave a yellow flag if something is coming down the pike that I need to know about. And just wanted to advise y'all related to the Virginia Health Benefit Exchange. We were asked to nominate a professional for the advisory committee who early on has been waving the flag of concern that the new health benefit exchange would allow direct enrollment and enhanced direct enrollment, and it looks like that's going to be delayed for potentially some years. So I'd like to ask Lee Budrecki, who is our representative to the advisory committee, just to briefly let you all know what this is, what our concern is about. And I know we've reached out to a couple of you, but Lee Budrecki.
Mr. Chairman, members of the committee, Commissioner, Secretary. As Bob mentioned, I was honored to be appointed to this committee, having sold ACA policies every year since the inception, and having built our own platform that was operational before healthcare.gov. I've spent more than a little bit of time dealing with the normal consumer and the decisions that they have to make. I think it's fair to say that anyone who supported the standing up of an exchange in Virginia did so believing that Virginia would have its own healthcare.gov. And unfortunately, that is not the case. The exchange vendor as chosen so far has basically a mono-agent or agency enrollment mechanism that is not compatible with Virginia's existing insurance distribution. My agency was founded in 1984. This is my 21st year. Health insurance in general is transmitted through general agents, managing general agents, and in my case, primary agencies. In the exchanges that we have used for a decade, we have enhanced the consumer transparency tools, and we have built all of our policies and procedures around protecting the consumer when subsidy eligibility verification documents are lost at healthcare.gov and other practices. Without the ability for me to manage my 400 1099 and W-2 agents operating in the exchange, it would be a very difficult reach to say that enrollment will not be impacted. Furthermore, with the exclusion of DE and EDE integrations, all national brokers will be excluded from selling in the Virginia marketplace, for example, ehealthinsurance.com. On a personal note, I couldn't really be but so upset about that. But the reality is that this marketplace, as you're aware, has what has been cited up to a 40% churn rate. Agencies like mine do these enrollments for a consumer service mission relative to our agencies. And the thing that I am really struggling with is how, when net new enrollments indicate the health of the pool enrolled in Virginia, it would make any sense to artificially restrict the distribution for this exchange. Furthermore, when we look at the unwinding of the public health emergency, that's 20,000 people, some say, a month needing help. Agents are the only ones in Virginia that can assist the consumer in choosing a plan. While the public health emergency is a big deal, I submit to you that this final rule on the family glitch turns the public health emergency issue into a mere ripple in a giant lake. We're talking about nearly every blue-collar dependent and child now being eligible for a subsidy on the marketplace. The coverages with their now current group policies, when compared to the individual marketplace, are as different as night and day. The commercial markets generally have all doctors and all hospitals in network. The ACA plans operate by leveraging micro networks in order to achieve volume scale discounts. Point being, I am very concerned at the net new enrollment viability when all 8 managing general agencies of Virginia are unable to support their downline agents. Secondly, I'm very concerned at my agency's ability to support the consumer because rural and non-insurance fluent consumers, most of us, are not going to understand the differences between the exchange marketplace and their current group coverage. They will see a $500 to $700 difference in their household budget because of the subsidies they're newly eligible for, but not necessarily understand that they may be losing their specialists, their facilities, or their chosen hospital system. I am not sure why, after a year of me asking this question, we're still here. In the beginning, I thought it was easy. We just identify where healthcare.gov missed a block or a tackle, and Virginia can go back to leading the nation with some of the smartest health insurance regulation in the nation. You know, funny, when we're talking about this essential health benefit, in 2006, we didn't deal with any of this. Virginia, because of its mandated benefits, had already addressed many of the items except for the subsidy that were placed into law by the Affordable Care Act. So now here we sit The federally facilitated marketplace is recognized in order to get enrollments, you have to meet the consumer wherever and whenever they're willing to buy, just as Amazon, Kayak, and any number of web vendors that you can think of. Without my agency's direct enrollment and enhanced direct enrollment integrations, I will effectively not be able to service the 22,000 applications we have submitted to the federally facilitated marketplace over the last 10 years. I implore this committee and the SEC to revisit the integrations that were built and tested with the chosen vendor, Get Insured, that were also operational as of November 1st for the Georgia Exchange. My humble request is that instead of turning off these integrations and reducing the consumer's access to the only help in choosing a plan, that we leave that button on and open the 2024 open enrollment with as many enrollment assets as available. With that, I thank you.
Thank you.
Mr. Chairman, may I ask him a question?
Sure.
Sorry.
Delegate
I think I have to-
Sullivan.
Very early in your remarks, you mentioned a decision about what was it?
So in the federally
Do
facilitated
you remember what you said?
Mm-hmm.
What was it you said?
Mono agent or agencies.
What does that mean?
That means that with the Get Insured platform.
And that's an online getinsured.gov platform?
It is the IT vendor chosen by the state to provide the Virginia Health Benefit Exchange.
Okay.
In that environment, an agent can sign up to be able to perform enrollments.
Right.
And an agency can sign up to perform enrollments. I have 45 agencies underneath my hierarchy and around 100 1099 agents, all of whom I manage in a HIPAA segmented and partitioned multiple exchange hierarchy.
So my question, sir, is what decision was made that prohibits you from doing that?
To not include direct enrollment and enhanced direct enrollments in the first year of the Virginia Exchange opening.
And say that to me in English. I don't know what that means.
The electronic tools that I use.
I'm a consumer, or I've come to you. You can't sign me up because why?
There are no coverage comparison tools that I am able to use to clearly articulate the pros and cons of one plan versus another.
And is that because they don't exist or because you've been denied access to them?
It's because they're not turned on.
Okay, so, and who decided not to turn them on?
I believe the exchange slated this for a year 2 priority out of concern for being able to get it done in year 1. However, the exchange is on a commission-only pay plan, and I submit to you that getting every enrollment possible should be the priority.
So the exchange made that decision?
Yes, sir.
Okay, thank you, sir. Thank you, Mr. Chairman.
Certainly. Yeah.
Good morning, everyone. I'm Holly Mortlock. I'm the Chief of Government Affairs and Policy for the Virginia Health Benefit Exchange, and just wanted to thank Lee for his comments, but also just to share with you that I think we may have a little misunderstanding. The Virginia Exchange has not made a decision as to whether or not to include or not include enhanced direct enrollment for this year. We have been engaging with our brokers and agents, which we recognize are very valuable members, of the exchange community and helping to facilitate enrollments. But one of the reasons that we are continuing to engage with them is that including this functionality in the first year. Well, first we'll say that there are 18 state-based exchanges, and none of those exchanges have EDE as part of their process and functionality. Get Insured they're in 7 states and have successfully transitioned 3 exchanges from the federal exchange to their own state-based exchange. We recognize that this is a concern, of the agents and brokers, but we continue to engage with them, to hear them, and to try to find the best path forward for Virginia consumers, and our agents and brokers. So just wanted to clarify that for you. Also, if we were to include EDE in this first year, it would cost $3.5 million. and increase the complexity, the technological complexity of the transition. So these are some of the key factors that we are considering as we are moving forward with our implementation. But just wanted to reiterate to you, our ongoing commitment to be working with the agents and brokers, and we'll continue these conversations with them over the next year and through the implementation.
Mr. Chairman, could I?
Yes, Delegate Ware.
Recognizing the financial challenge, but also recognizing that, just as the earlier exchange with my colleague indicated, we ordinary folks that don't understand, I didn't understand 75% of what he just said, but what I did, I think, understand is that without him or people of his type, I'm going to be in a worse shape not having access to them to give me a better understanding. The last thing he said had to do with putting a button up there or not deleting a button, or sounds to me like something that's online. Is it possible to do that?
Sure. So it is possible to do that, and that is something that we have considered doing. I will say that state-based exchanges overall, and again, none of them have enhanced direct enrollment functionality, they do a better job of enrolling and retaining enrollment of consumers in their marketplaces. So that is one of the key reasons that states have gone to state-based exchanges, are those data points that demonstrate how much better state-based exchanges do in obtaining and retaining enrollment. We recognize that this is a change, and we are, like other states, will be working very closely with our agents and brokers on a monthly and weekly basis to make sure that they have the tools that are necessary to support them and to be successful in this transition. And enrollment is the goal of everyone, and we want to make sure that we are making sure that they have the tools to be successful. So again, we are happy to continue these conversations. I think at this point, the complexity and the cost for this year does seem to be a bit of a risk. But again, we do continue to engage with them. This is an option that we could consider in future years. Also, if it were to appear that would be in the best interest of Virginia consumers and our agents and brokers and our carriers as well.
Delegate Sullivan.
I'm sorry. What did you call it? EE? Enhanced enrollment?
Enhanced direct enrollment.
Enhanced direct enrollment. And I'm with Delegate Ware on this. Some of this is at least new to me. What is enhanced direct enrollment? What does that mean?
Sure. So that is, I will turn to the
It's the hour is late, so as briefly as you can, sir. What does enhanced direct enrollment mean to me, a potential consumer?
That means that private and web brokers are able to operate private exchanges, which
Okay.
have a higher expense security-wise, to market to the consumer in order to create awareness, generate enrollment, compare plan coverages, submit the subsidy. I'm able to do an enrollment in about 4 minutes with my existing system.
Okay, so that's a good marketing pitch. But so the point is, at least what you're suggesting, ma'am, is that you don't think in the first year you can either afford or accomplish that, even though you agree that would be a good thing for the consumer.
So I think that it is. So I think it would be a technologically complex thing to implement in our first year of transition, and it would also be expensive. Whether or not that is in the best interest of the consumer, I don't believe that we have the data to support that. What I do know.
So I'm sorry to interrupt. So are you suggesting to the committee that you need more time and more money to accomplish it, or you're not even sure you want to accomplish it?
I think that is a conversation that we need to continue to have with our.
So the answer is you're really not sure. You're not sure it would be good for the consumer to have this EE.
I would say that we are not. The data, we have not seen the data yet to support that in a state-based exchange that would be critical in serving the consumer. I think that the data still needs to bear out, but we are happy to continue the conversation with the agents and brokers. We have not turned that option off.
Thank you, Mr. Chairman. Thank you, ma'am. Thank you, sir.
Anything else?
One last comment. I met with the CEO of the vendor that was selected a year ago. I've been asking this question for nearly a year. And the only point at which I got an absolute answer was after the RFP was awarded in October. Ladies and gentlemen, it is a big deal. The data is not going to necessarily bear out because other states will have a single carrier marketplace. Virginia has 6 distinct different marketplaces wherein a consumer, if they enroll in the wrong plan, will lose access to the hospital system that they would most likely go to. I would submit to you that this should have been a first priority in enrolling under the exchange and should still be a first primary. The citizens of the Commonwealth deserve the assistance.
All right, is there anyone else wishing to comment? Public comment?
If you are in the Zoom room and would like to speak, please raise your hand electronically. We have one speaker, Mr. Chairman.
Okay.
Elizabeth Carr, you may unmute and begin.
Good morning. Can you all hear me? Thank you so much for having me this morning. Excellent. I am happy to be here in front of you again today, and I will not take much of your time as I know, there are still a lot of questions surrounding process as it relates to the EHB. But I come to you today as a daughter of the Commonwealth of Virginia. 40 years ago, I was born there via IVF, and I actually happen to be the first IVF baby born in the United States. And so I am continually grateful to the Commonwealth of Virginia for being ahead of the curve. And this is not my first rodeo. I am coming to you in front of this committee urging once again that in vitro fertilization is actually considered and put into the EHB. As we know, infertility affects 1 in 8 couples, which is not an insignificant number as it relates to the Commonwealth of Virginia. And it should be considered an essential benefit simply due to the fact that, infertility and IVF itself is not an elective procedure. It is not considered the optimal way to go about having a family. My mother is a prime example of there was no other way she could have a child since she actually did not have fallopian tubes. And if you know anything from your childhood sex ed classes, you will understand that those pieces are critical in terms of conception. So I won't take much time. I know you all have hotly debated, the process surrounding this. I'm just planting the seed that I do hope you consider IVF to be considered essential in the EHB. And thank you so much for your time.
Anyone else to testify? All right, anyone want to make a motion to adjourn?
So moved. Second.
All right, all in favor say aye. All opposed, no. We are adjourned.